a list of programs that are topics that residents have submitted to me for various programs coming up this year and in the future. And I've been doing this now for about 5 years on the Wellness Committee. So there have been programs in the past that we've had to cancel due to a lot of different reasons. And so they're re-entered. And if you have any ideas of, well, you don't have to look at it now, but you can look at it when you have leisure time. Look through it, and if you have some ideas, we'll really appreciate more input about anything related to wellness. And that's all from me. You might want to silence your phones and let Debbie start right away. And thank you, Debbie. In case I don't get a chance in the end, we'll all thank you for your participation in the 3-part program. And thanks for attending.
Thank you, Kathy. And she said, and Hank too. So, thank you, Hank. This is it for us. And I'm going from, wait, do I have you in the right place or do you have me in the right? Okay, so I'll stand here?
Yeah, you're fine there.
Okay. So I think we have slides and video this time, which is, only worked all the way around, but that's because we're using their computer, so mine's just here kind of as a fake. But I'm so glad that you're here to see the third part, the part that I love the best, because it's medical. And gosh, more than 4 decades in medical. I try and get some of it right at this point, but I had a real early patient visit this morning and learned a lesson from a caregiver that I've never heard before. I'm going to repeat it to you because we may need it at some point. We have a gentleman that we are guardian for, and it's a very tough new case, lots of family discord, and so the court named CareFor to step in and be the legal guardian. Their dad has some pretty advanced dementia, and we were having a lot of violence and problems in the home. And so, under court order, he is in a dementia facility for the next 90 days while we try and get staffed up, get his medications adjusted, so that the goal is to take him home after 90 days if he is safe. He's been there 30 days, he is still not safe, and we are still not stable, but that doesn't mean we won't get there. And there's only one caregiver that has worked really well with him. So I went out at 7:30 this morning to meet the caregiver and ask him why it is that he is the only one that gets along with this gentleman who is spending all of his day, every day, what we call exit seeking. He's trying to find a place to get out of the facility. And everyone has stopped him and given him medications and talked him down and made him more angry, and sometimes been successful. And the caregiver told me, he said, well, I'm just his partner. We both try and exit. Every single day, we are partners, and we look for the exits, and we try them. And when they fail, we try another one, and we sit down and we make a plan, and I'm like, that is brilliant. He loves this caregiver. He never gets agitated with him. He can talk him into taking his pills. He is his partner. And it was just another one of those aha moments of, we always learn the biggest, best lessons at a granular level. And that is what a lot of this is when we talk about healthcare, is cross-pollinating great ideas. So I thought I would just pass it on to you. You may never need it, but you may need it. And if you do, hopefully you'll remember it. We are here because of the Wellness Committee, who brought this program forward. And as Kathy said, we really would love to hear any other programs that you would like, whether it's, we had our low vision group this morning and talked about low visions and things and some tricks, and I thought I knew something about it, but gosh, I knew 10% and they knew 90%, so coming back with 2 pages of notes and lots of pictures of devices. So anything that we can help you with, whether it's mobility or cognition or moving around or socializing, whatever it is that can keep you guys and us in our independent as long as possible. Any wild idea you think of, give it to Kathy, give it to me, we'll bring it forward, and we will provide you with additional information that will be helpful. What we are going to talk about is coming from the blueprint. We've gone through the legal, we've gone through financial briefly and personal, but now we're in the medical where you can write down your medical wishes and how important that will be for your family members. There are probably 2 reasons to do this. One is to save your responsible party, because when they have to step in and make decisions that they're not sure if it'd be your decision or not, and they may be guessed wrong, and you have months or years of being kind of tortured with the decision, or the decision is to not do something and they have the guilt of, was it on you that your parents not alive, or your brother or your sister? And that's heavy stuff. So much heavier than them following your wishes in writing that you've talked about, you've signed it, you've dated it, you've given it to them, and then they're applying your wishes. They're not making those decisions. So that's the first reason. The second reason to do medical planning has to do with aging your way, making your own decisions, having voice when you might be voiceless. You might have hit your head or been hit by a train or whatever, but whatever the reason is, you can't speak. Your documents can speak for you. We would all love to live our very fullest to the very last day of our life, and then we're gone, and that's it. This is the way I want to live. Right there. That woman, that's me. With my cape and my helmet and racing down the road, being completely independent. I hope it'll happen. The likelihood, percentage-wise, is single digits that will be the way it will be. Living fully active, fabulous, and then it's the end. So what we're here today to do is not that. No one benefits from that. You don't benefit from it. Your kids don't benefit from it. Nobody does. Let me try and catch one of my 2 slides up, okay? This is the worst thing that we can do, but is the most natural thing. Did any of you read over those documents that we passed out last time as far as concessions and medical decision making? Did it freak out anybody? Yeah, it did. Yeah. I've had some real harsh responses to some of that. So we're going to go through it as a group and just jump in anytime that you want. This is my promise to Robin. The promise is that no one here is going to expect Robin to make their medical decisions. I promised her that I would pass that along. Because when things happen, as close as we get with Robin, she's our nurse that's going to keep us in independent living. She's the one that shows up when you pull the cord. We expect her to jump in and be there and take care of it. She will take care of providing information from her little sheet of paper. She'll take care of calling EMS if it's appropriate. She will not make your decisions for you. She can't make her decisions. And it's not her place to do that. It's not the place of the hospital doctor. We now call him a hospitalist. You know, your family doctor used to see you in the hospital. They'd make rounds first thing in the morning when everyone was still sleepy. You'd be groggy, you'd say a few words to him, you'd fall back asleep, and then you couldn't remember what he said because he came so early, because he was on his way to make his rounds, get finished, and go to his office practice. Well, that doesn't happen anymore. It's a hospitalist there, and typically they're going to do 2 days in a row where they take care of your illness of the moment, and then after 2 days, they hand you off to another doctor, and they do their job for those 2 days and hand you off again, which means they're not going to make any decisions for you. It's unethical because they don't know you. Our old Dr. Robinson that made house calls to the house, he could have made my decisions. He knew the family, our religion, our larger family. They knew everything that we would do or not do. This hospital's a total stranger. So it's unethical for them to make decisions, and it would also put their liability insurance so high they would have to quit practicing. So they will not make decisions for you. This is where we get into the documents that we handed out. Now, does everyone have their pill bottle in their refrigerator that has your information sheet? Does everyone know what I'm talking about? Okay. That has your responsible parties, your family members, your health insurance. It has a little bitty area for your doctors, and I took out my tape measure and I measured it. It's 1/2 inch by 2 inches. Now, who can fit their doctors into 1/2 inch by 2 inches? It's not going to happen. Maybe you can fit it on a half a page. But what we need to do is supplement what Westminster does. They update that once a year, and we need another piece of paper that we update every single time there's a change. And the 3 most important things are: who are your doctors, what are your medicines, and what are your medical conditions. If you have on your sheet that you have 1 knee replacement, and next week you'll have 2 knee replacements, it needs to be on your sheet. That's not a lot to keep up. But once you start doing it, you realize how much changes every time you go to a doctor. This med comes off, this med goes on. You take doctors off that hurt your feelings or you get mad at, or you just don't want them anymore. You don't want them still on your list because they could be called. So every time there's a med change, a doctor change, or a new diagnosis, you need to keep it caught up, roll it up, and put it in your pill bottle in the refrigerator. And then you don't have to worry about it, because that's the only thing that will be communicated when they come in, is that information. And you sure don't want them operating from old information. You know, if all of a sudden you're on a blood thinner and you hadn't communicated that, it's a huge difference maker when EMS comes. So if anyone has trouble formatting that, where they need help on the computer to get it on a Word document, holler at me. I'll help you get that done, because I've seen too many medical mistakes that were not on the hospital or the ER. It was on the patient or the family not communicating that. So that's a pretty critical piece for all of us to take responsibility for. Now we're going to go through the medical planning worksheet, the priorities, the concessions. We're going to look at providing all that information to our power of attorneys, and then we're going to go over the out-of-hospital DNR form for EMS, which for some reason I think is always going to continue to be confusing, but we will go through it. Who had a concession that they wrestled with when you looked at the concessions that you would be making? Nobody? Yeah, I know what yours is, Hank. Go ahead.
Driving, don't take the car away from me.
Yeah. Driving. Driving is a huge one. I don't know why, I know why for Hank, because it's part of his therapy. If he does not get out of the car and drive on his own and go somewhere and do something every single day, I don't know, there's something that happens to him. It's just not right. He doesn't feel stable. So we had a big discussion about this. And he put in writing, agreed to, signed, and all the children know it, is when both the doctor and all of the children tell him he can no longer drive, then he'll quit and it's signed. Because I have had patients that will not concede with driving. But now we have that we will get an Uber or a Lyft, and that's the way we'll go. I've had people that drive, that have a wreck, they leave the car on the side of the road, they go home and they call the dealership and have another car delivered. And that's true. It is a true story. What dealership wouldn't? So, yeah, look at the concessions. The concessions where you live. I know we're here and we, in this wonderful continuum of care, we can stay here the rest of our lives, but there are different levels of care. And especially for those of us that are couples. When one needs a different level of care, what are you going to do? It's easier to think through that, come to an honest decision, write it down and share it with your power of attorney. Because you can either agree to move to a different level of care, you've already paid for it, do that, or do you want care brought in? Halcyon's on site here. They can start caregivers. You have choices, but your kids need to know, or your power of attorney needs to know what the choices are. Because you may have to move out of your apartment that means so much to you. You may have to be separated. One of the ones that's a little unique with Westminster people is when your family is remote. Because I can't even venture a guess how many people we've moved in from other states to Austin because their children lived here, their parents were aging, they couldn't see them enough, they couldn't go visit them when they fell and went to the ER. So they contracted with us to help move them to Austin, get them set up either in a home or a facility or whatever, but to do that transition with their medical care and so forth. We've bought life care. So we'll be less likely to go move and be with our kids that live in Ohio when the time comes. But what if they're pressuring you to do that? And that's really what they want. That should be your choice. That you have communicated to them, you are not moving just because they want to be near to you. Needs to be documented and discussed. Because you can select someone locally to be your support, whether it's your neighbors that live next door and they're a generation younger and they can show up in the ER and call your kids and do that. You can contract with the care management company. Care4 is one, but there are probably 4 or 5 care management companies So you can have local support, but that needs to be prearranged and decided so it isn't something that happens in a crisis and you have to move from where you want.
So,
Pets.
Debbie, real
Yes.
quick before you go to pets, having been on the remote family side of things, my brother and I, one of the things to understand that your kids are facing is when they are talking to all of their friends, one of the first things the friends say when they begin to realize what you're doing is, so, have you thought about moving your parents to Oregon, which is where I live? So the kids are getting a lot of pressure, even if it's sublime pressure, to move their parents to where they live. And I can tell you right now, my dad has zero interest in leaving Westminster, and we're not about to move them. But the kids are getting that pressure that you may not be aware of.
That's very true. Children can get pressure to move their
And
parents.
they can feel guilty about it.
And even if the decision's been made and the parent is where they want to be and they're cared for, the kids get that pressure. So it is helpful to discuss it openly, to document it, and to say, I'm honoring my parents' wish. Because that's what it's all about, is getting what you want your way. So it is hard for the kids. It's very hard. Thank you for sharing that. Now, how many here have pets? Yeah. And how close are they to you? Do they mean anything to you? Yes. Yeah, they mean everything. And what about when you can't walk your pet? And your spouse can't walk the pet? What are you going to do? Dog walker. Does that sound like a solution?
Yeah.
Yeah. There's a price tag that comes with it, most times, if you want a reliable dog walker. But that's important. And if your pet is that important to you, it needs to be documented. I have the reverse, because, you know, us weaker sex, we live longer than our husbands. But should the reverse occur, and I die first, it is written on here, the day I die, Hank gets a dog. All the children have been told, but this is very important, and it can't be left out when you talk about your aging plan.
You're not dying, sorry.
Gosh, okay. All right. Here's the heavy one. Did y'all read through this? Okay. What this is a communication to your power of attorney, because the legal documents will say something like, for the directive to physician, if I have an incurable or irreversible condition, I would like everything done, everything, to keep me alive, or I want comfort care. That's the black and white of it, and most of hospital care is very, very gray. Probably the only good thing that came out of COVID was opening our eyes, realizing that healthcare needed a discussion and that things could change in an instant. They can for us at our age, but not usually for the younger people, so it started a country dialogue. And that helps this medical planning worksheet be more relevant to people. If you're in the hospital and you cannot communicate, you are nonverbal, you have been injured or ill to the point that you cannot participate in your care at all, and your responsible party is here to make decisions, again, we're going to go back to earlier. You don't want them making decisions, you want them applying your decisions. So walk it through. Here are the things. CPR. If you're in the hospital, you can't direct your care. Your heart stops, you stop breathing. Do you want CPR? Do you want someone to attempt to bring you back to life? Yes or no? The next step down We break it down. What about breathing support? We learned all kinds of stuff about breathing support with COVID because everyone that got COVID got intubated instantly at the beginning. That's a breathing tube being put in your mouth, down your windpipe, hooked to a ventilator, and it breathes for you. It protects your airways so you don't stop breathing. It wasn't so good for every COVID patient. Same, it's not so good for every patient in general because it's hard on you. So the alternatives are, you start out potentially with external breathing. Does anyone have familiarity with a CPAP machine or a BiPAP machine? It's that external mask. And it's a lifesaver for people that have sleep apnea and need that. For other people, they do not want a mask on their face. They'd rather be intubated than have a mask because there's a feeling of suffocation. Let people know, would you want external ventilation? Would you want a breathing tube? Breathing tube can only stay in maybe 5 days, something like that, because it's going through your voice box. It's going through where you swallow. And so if it stays in too long, you can have permanent damage. So if it's apparent you're not going to come off of it, they do a little surgical incision into your trach. They do a tracheostomy and put the tube there. It sounds bad. It is tons more comfortable than a tube through your mouth and down your windpipe. But let people know. I have patients that say, you can put me on breathing support for 3 days or 5 days. They give me specifics. But at the end of this time, if I'm not able to come off the ventilator, you stop it. This is your opportunity to write that down. Only if you can't participate in decision making. Then we go to nutrition, which everyone gets an IV when they roll through the ER doors. That's just what happens. But quickly, you need more nutrition than that. You need the fats and the vitamins and the minerals, like baby formula. And so quickly people have to progress to a feeding tube. That's artificial nutrition. It's life support. People don't think of it as life support, but it is. Do you want that? That can go in a little tube through your nose down to your stomach. But again, it's limited, a week, maybe 2 at the most. And then it's too annoying. And it's potentially too dangerous, so you have a small incision directly in your stomach, and the tube gets put in your stomach, and you get your nutrition that way. What would you want? And this is if you are in a condition that is a grave condition, where you're not expected to recover and become independent again. For someone to approve it, either needs to be a limited period of time, or they are approving it for the long term. There are people I've worked with that approved it because they were terrified, they hadn't had the discussion, and they wind up with the feeding tube, and it's years and years, because once you're on a feeding tube, you can always make the decision to come off of it. But I haven't seen a family member comfortable with that yet, and I've been doing this for 45 years. So think about it. If you have to have a permanent feeding tube, put some thought into it. You can live for years and years and years and years dependent that way. Your choice, not a right or wrong, but it needs to be looked at. Is that what you want? Renal dialysis. When you're really sick, your kidneys can go into shock, and you can need very brief dialysis to wash your blood, return it to you, get you stabilized. But long-term kidney failure, do you want to go to a dialysis center 3 times a week and spend a half a day 3 times a week? Some people do well. I remember a sheriff that would go get his dialysis, and go on and do his sheriffing duties, put his gun on and go to work. Also know people that are sick for 2 days afterwards, and you don't know that until you're there. So think through it. Renal dialysis, pacemaker, invasive tests like a heart cath or colonoscopy. What of these things do you want if there is little to no chance of you recovering? Communicate that to your family, because they may be hearing it for the first time. This is their reference sheet. It's not a legal document. This is their reference sheet, because by the time they need it, it's 5 years, 10 years, 15 years later. They need to have it in writing. You owe it to them. Things like blood transfusions, IV antibiotics, any major surgery. Often when someone falls, hits their head and has a cerebral bleed, they also break their hip. It kind of goes together. In that circumstance, do you want to have surgery and have your hip pinned if you don't have a chance of recovery? Think through these, and if you're kind of at a place where you're uncomfortable, give me a call. We'll talk about it. Because what's important is that you understand it. Not that you answer it right or wrong, but that you understand what you're answering. Down here it says comfort care. I have never had anyone say no to comfort care. So don't say no all the way down. Comfort care is something else. And organ donation. Do any of you have that on your driver's license that you're an organ donor? Good. They won't donate your organs based on your driver's license. They'll bring up the topic, but they need your power of attorney to approve it. So make sure it's on there, and if you don't think you have organs to donate, you're probably wrong. There are all kinds of organs you can donate. Your heart, your kidneys, your pancreas, your intestines, your skin. There are 9 organs that you can donate. So, yes?
Is there an age in which you're too old to be an organ donor?
I thought there was an age where you were too old, but organs are very precious, and although it is a topic that's discussed a lot, there are not enough organ donors. So it doesn't hurt to put it there. If you just are too old to do it, it hasn't hurt that you put it there. But it's a good clarifier if someone asks, that you don't have to wonder.
Does it need to be on your driver's license?
It should be on your driver's license. However, if it is not on your driver's license and your power of attorney says, yes, my mom or my dad wants this, they go by the power of attorney. And then this is discussed and signed by everyone. Yes? The 2 columns are close. One is that there is no chance of recovery. It's like when someone has a stroke and the doctor will come in and say the brain is a complete whiteout. There's nothing in there. They cannot recover. They will not recover. It's definitive. But it's rarely that extreme. Often it's, there's a bleed, it's already caused this damage, or there's a clot and you can't get it out of the brain. So there is going to be permanent damage. They just don't know how much you'll recover. There's a remote chance that you're going to recover. Not to be independent again, but there's a remote chance that you will recover to the point that you will have some ability to think and some ability to function. Would that change your answers? And some people, it changes a lot depending on your possibility, not probability, but your possibility of recovering. So they are two different categories. Does that answer your question or not? It's fairly, it is gray. Everything in healthcare is gray because it changes. You know, you can fall and feel like you broke your leg, and they can take you to the ER and x-ray you, and it's still bothering you 2 days later, but your x-rays were clear. You go back, it's broken. Information isn't stagnant in healthcare. And so there is a gray area where all someone can do is tell you what they think the potential is. This is what will help your responsible party feel their comfort level as far as responding to it. All right, we're going to go on to, are there any other questions on this? All right. I want anyone to tell me what a do not resuscitate means. What is this form for?
No CPR.
No CPR. Right. Where?
Out in your home.
Yes. That's the distinction. And it says so right off the bottom on the top. It's really small. But it says out of hospital, do not resuscitate. It is only an EMS form. It is only for the community. Whether it's at HEB, whether it's at Westminster, whether it's in skilled nursing or a rehab center, anywhere out of the hospital. And we'll go into what it means once you get in the hospital in a minute. But this is the only form that will stop EMS from doing CPR. You can have it in your advance directive. You can have told every children. You can have told Robin. You have everyone. They will do CPR, even if you say you don't want it, even if your spouse says, my wife does not want this, they will do CPR, unless this form is shown to them. It's a tricky little form. Everyone that signs it has to sign once to say this is what I want, or this is what my spouse wants if they're the responsible party. And then everyone that signed above, including the doctor that says, I get it, I'm putting it in their medical record, every single person that signed above has to sign a second time at the bottom. There are a lot of them that aren't done correctly. So it's important, and Westminster can help you with this, has to be witnessed by 2 people. One can be your family member. It has instructions on the back. It does not need to be notarized if you have the 2 witnesses. But make sure it's done right and that you have tons of copies, because what happens is EMS shows up, they will do CPR unless someone waves this in front of their face. And when they wave it in front of the face, EMS will often say, oh, they look okay, I think we should do CPR. They'll push back. I had an attorney that told me recently at a recent presentation that I was doing with her. She stood up and said, when you call EMS, there is an assumption that you are negating your do not resuscitate. And I said, no. Because EMS, they can stop your bleeding, they can help your breathing, they can stabilize your leg or your neck if you need that. They can do all those things. This is just CPR. But she has worked in situations where EMS came through and said, you called me so you get CPR. That is not true. But sometimes you have to push for it and say, We did this. This is my spouse's wish. No CPR. Westminster will support that because they understand the document. This only means no CPR. It means you have no heartbeat, you are not breathing, you are dead. They only do CPR if you are dead. So this is a I've died, don't try and bring me back form. Yes?
If I'm elderly and I'm driving and I have an out-of-hospital DNR, should I pin it to my?
Absolutely. It should be tattooed on your face. Mine is in my glove box, but I don't expect EMS to look through my glove box. It's also on my phone. Some people get CPR when they don't want it. But this is the only thing that EMS can respond to. Even if you take your DNR and show it to them, they're not going to read a legal document. They're not allowed to. So this is for the entire state of Texas. It doesn't change anywhere in Texas, and each state has their own form. Now, once you roll through the hospital doors, you're a full code every single time you go to the hospital. Sounds strange, doesn't it? But you also have your family member bring your out-of-hospital DNR form with you. That's why I say make bunches of copies. Because everyone that touches you, EMS will take one copy, the ER will take one copy, the specialist will take a copy. I have no less than 20 copies because everyone takes their own copy and they don't ask permission, they take it. So make lots of copies which are every bit as good as the original. But once you go through the hospital doors, the reason everyone's a full code is the doctor, in conjunction with the whoever your responsible party is, they have to evaluate that hospital stay. Because if you're going to have your hip pinned or your cerebral bleed drained, you're going to be in surgery. You will be on life support in surgery. You don't go into surgery being an out-of-hospital DNR. You go into surgery, a full code, get put on a ventilator until you're recovered. So every hospitalization, the doctor has to write what kind of a code you are. Full CPR, no CPR, or the stages between. It may be that they will intubate you, but they won't shock you. Or it may be that you be a chemical code, which is they'll give you IV medications to restart your heart or increase your heart rate or your blood pressure. But they won't do intubation and they won't do any shocks. That has to be discussed with the doctor at every hospitalization. But it helps to have your out-of-hospital DNR where you show it to them. And you say, this was Mama's wish, so that they know that. But it's just an out-of-hospital form. Are there questions on that? Because there usually are. Okay. This is my favorite person I miss every day. It's my mother-in-law, Lois. Wonderful lady. Wonderful, wonderful. It's where Hank gets his temperament. I will never have that temperament. I wish I would, but I never will, as long as I live. But that was Lois. She lived in Austin for the last 5 years of her life. We brought her here from California, straight out of the ICU, where she'd been on life support, right to Austin. Didn't need to check over her house, didn't need to pick over things. She knew she needed the support. She's like, oh, that's a great idea. Let me just move to Austin. Who would do that? Only Lois.
Mhm.
She was just, her glass was always full. But Lois had congestive heart failure. And this is our little granddaughter, one of them. She went in congestive heart failure, had way too much fluid, went to the hospital, had the external ventilation, was pretty critical, got the fluid taken out of her system, went back home, and she was doing okay. Until not long after that, maybe a month, 6 weeks after that, she wound up back in the hospital again. Couldn't breathe, external ventilator, taking the fluid off. We went to see her the next morning. Well, actually, we flew home from family vacation and then went to see her. And something had changed. She wouldn't eat. She wouldn't talk. And the biggest thing that we knew we were on really scary ground is the newspaper sat on her overbed table and she never picked it up. It was what she did every day of her life. It's how she started every day. She wouldn't do anything. So we met with the doctor, the cardiologist, who's also Hank's cardiologist. We have a very close relationship with him. And asked, is Lois appropriate for hospice? And he said, oh, absolutely yes. She was 91. Her heart was giving out. He was a good friend of ours. And he never mentioned hospice, ever. I see this time and again. People can be ready for hospice, be totally appropriate for hospice, but the doctor won't suggest it. Even the oncologist, the cardiologist, the neurologist, they won't even mention hospice, and I don't know why. It was heartbreaking that we had put her through what we had put her through when she was hospice appropriate. So anytime you have a loved one who continues to fail, you have to be brave enough to ask the doctor, is my loved one appropriate for hospice? We got together as a family, talked about hospice, went into Lois's room and said, Lois, if we have a plan where you will never have to come back to the hospital ever again, is that the plan you would want? And she had the biggest smile. She said, absolutely, if you can promise that to me, I will be so happy. Please give me that plan. And so the family that was terrified to say the word hospice was silent, and I said, well, there's a great hospice agency that can see you at home, make you comfortable, do everything that you want and need. Their whole focus is going to be on your quality of life, and you will never have to come back to the hospital again. She picked up her fork and started eating. She was thrilled. She went home. Hank, I don't know how long she lived. 3-4 months after that. I can't remember how long she lived, but I remember the day she died.
2.5 years.
This was a very active lady, and she was never in bed. But she was in bed that day, early in the day, and she's picking like this. And Peggy, you know what I'm talking about. Picking like this, like so many people do when they're getting close to death, and they start seeing beautiful things, lights and beauty, and they're reaching for it. And I knew, I'm smart, I've been here, I knew exactly. I said, Lois, are you seeing something beautiful? And she said, no. She said, if I don't exercise, I'm never getting out of this bed. We're all so smart. She did get out of bed. She got to her recliner and she died. She was not going to do it in bed. What this brings me to is it is never, ever, ever too early to ask about hospice. Doesn't cost a thing. It is covered by your Medicare 100%. It doesn't cost anything to have a hospice evaluation. And you don't have to stay on hospice. I've had plenty of people graduate hospice. But they're in a really low ebb. They don't want to go back. They don't want anything. You can put them on hospice and they're reevaluated every 6 months. So it's a wonderful, wonderful service. What could be bad with any service that focuses on comfort and quality of life? So that's my hospice pitch. This is, if you've done all your homework, this is your crossroads. Denial and chaos, or make yourself a blueprint that you think out, discuss with your medical team, put in place, document it, communicate it, and give it in writing to your family. That's their gift. Read this. It's true. Care staff are not robots. Due to the shortage of robots, some of our staff are human and therefore react unpredictably when abused or under pressure. I hope we remember this with every single caregiver we pass in the hall, with every person, whether it's in the hospital, in the emergency room, at Westminster, in your apartment. That was the person that taught me my lesson this morning. The caregiver who knew how to help this man try and break out of the dementia facility. The caregivers are the ones that have all the knowledge, all the heart. They are the difference makers in our world. And I have seen caregivers be the most important person in the patient's life. I have seen them abused and treated like subhuman servants. The way you treat them will make a big difference. They may not be your choice. They will not look identical to you. The caregiver also has family with needs. How many times when people have a caregiver during that shift, does someone ring their doorbell or call their phone or come in and visit with them? Caregiver has family too, but they may be working 12-hour shifts. That caregiver does not divorce their life when they come and help you out. They have family too. I've seen them flourish with kindness. I've seen kindness to caregivers, and it just keeps bringing out the best that they can have. The caregiver shortage is very real, and it's very heartbreaking. We struggle with it in my company every day. I know Halcyon struggles with it. It's hard. So if you give a little bit to your caregiver, and if you kind of set your mind ahead of time, it is more helpful than all of a sudden you're in a crisis, you need a caregiver, and you got your panties in a wad and you're mad about it. So think about it ahead of time. These are the difference makers. At Westminster, it's a huge cost savings to have an on-site caregiver company. Caregivers in the community are at a minimum of $35 an hour, and the least that they'll come out for is 4 to 6 hours, if you can find someone to come out. With the contract that Westminster has put in place, You can get as little as 15 minutes. They're on site, they can come do med reminders, do little things for you, all the way up to 24 hours a day. So we're all in a good position because of the advocacy that Westminster has put in place for us. Doesn't mean Halcyon's your only choice. What it means is you got a good deal with this company here. Treat them kindly, please. We're wrapping up. And I hope you all know that hope is not a plan. You have the ability to plan. Hank handed this out, and you all have the handout. These are the things to do, is gather your information, document your wishes, put it in writing, share it with your loved ones, and let them follow your plan, not anyone else's plan. And husband and wife can have very different plans. You've been individuals. What questions do you have? And I would be happy to answer any questions. Or you could call me personally. Yes, oh, I'm supposed to stay here.
You indicated there was out-of-hospital DNR, but when you get in the hospital, can you sign an in-hospital DNR?
It has to be a doctor's order in the hospital. And the easiest way to communicate that is to take your out-of-hospital DNR with you and show it to the doctor. They'll take it, it'll get lost, so maybe take a few copies. But give them your out-of-hospital DNR. If you can talk, if you can't talk, your spouse needs to do that and say, this is Bob's wish, this is what he wants. He doesn't want to be resuscitated. If anyone resuscitates me, God help them in heaven. It will be a nightmare. I would never want that. But that's me. Hank is a brave boy, and he's all up for anything. But you know, there's some of us that are chickens, and so if that's important to you, you need to have that out-of-hospital DNR in your glove box so when something happens, or on your phone, because you can put them on your phone and in your medical information. Just make sure that somebody sees that, gets that, and the doctor knows how strong your wishes are. Because it has to be under a doctor's order, not a standing order. For every hospitalization, it has to be done with each hospitalization. So I'm so glad you asked that. Anything else? Yeah.
So, just an observation with the hospice. You've got the hospice nurse comes in, you've got a hospice organization, you have caregivers also, a separate organization. And just an understanding that the little emergency pull cord is still available, whether you've got caregivers or hospice. And that's one of the things we've had to make sure the caregivers know that if you have an emergency and you call hospice, you can get put on hold at 2 in the morning. And that doesn't fly. So caregivers need to be told if you're on a hospice, the pull cord with Westminster is still valid, and they'll be there in a heartbeat to take care of things immediately, and then you can follow up with hospice later.
That's a good point. Your dad's on hospice, he has caregivers, and there's an emergency pull cord. The way hospice works is there is a nurse 24/7 available. If something is needed, let's say the patient is suddenly in pain and the medication's not working, or they're nauseated, or they're anxious, or they're having trouble breathing, you're to call hospice. Because that nurse is available 24/7 is another advantage of hospice. So it's interesting what you would tell a caregiver, because certainly if a patient fell or the caregiver was having immediate trouble, they would have the ability to pull the cord to get some help from Westminster. But that would not direct the care. What directs the care is that that is a hospice patient. You wouldn't be calling EMS. You wouldn't be transporting to the hospital unless you revoked your hospice, which you can at any time. If someone has decided they're frightened and instead of hospice, they want to go to the hospital, you go to the hospital and your hospice stops, and then your regular Medicare takes over. But yeah, that's an interesting twist on how you educate the caregivers as far as pulling a cord. And again, it's another reason that everything needs to be communicated through Robin and through the nursing office there to say this is a hospice patient and it's on their record. So it may be appropriate to call EMS in some random circumstance, but that would be more appropriate if hospice says it's time to call the hospital. I've seen it very rarely.
Is Hospice Austin Westminster's preferred hospice if one is a resident?
Hospice Austin is the one that I have seen here the most. They're not, they may be their preferred, I don't know that because I've seen some other ones, but I've seen Hospice Austin here at Westminster more than any other. Have y'all seen anyone else? Any other hospice agency?
Yeah, I think one of their advantages, they're nonprofit, and
Right,
Dr.
it's a
Pellegrini.
long-term nonprofit.
Right, and
Oh.
Dr. Pellegrini mentioned that he thinks they may have been the only one in the Austin area that's nonprofit.
They are the only nonprofit in Austin, and they've been here the longest.
They
Yeah.
have Christopher House.
Yes, Hospice Austin has Christopher House, which is an inpatient facility. Some people, and it's more cancer patients, become very symptomatic at the end related to pain, and they're having trouble having their pain managed. And so they will go into Christopher House at the very end just for pain management or for a period of time till they get a pain plan in place that's working, then they can come back. Well, thank you all very much. Thank you for going through the session.